Good morning. Thank you very much for inviting me. This is a very interesting topic as a spine surgeon. I left spine surgery somewhere in 2015 when our new fellows came back from Canada. I gave up spine surgery, but still, the old tricks are still with us. So optimizing osteoporotic patients for spine surgery is really very important. We learn this by committing mistakes, and learning from the mistakes is average orthopedic surgeon does. Now, my disclosures are I have received some grants. I have to disclose since it's an invitational lecture. And this is the disclaimer, particularly I'm not associated with any company where I'm going to promote their products. But based on the literature and my own practice, our own practice at the university, I will be presenting that. Now, we know that it's a silent disease. Lately, we realized as early as in late 90s that osteoporosis is a major issue, which involves in the discrepancy of bone formation and bone resorption. Now, we diagnose osteoporosis based on the DEXA scan, based on the T-score. This is the various T-scores, depending on minus standard deviation. So whenever it is less than minus 2.5, we say osteoporosis. And then in some cases, minus 3 of the standard deviation, we call as severe osteoporosis. Now, in young patients who are not reached, say, about 30, 35 years, where you get the maximum amount of peak bone mass, we use a Z-score. Now, Z-score, in here we compare the patient's sex and age at the same level, whereas in the T-score, we want the patient, a 60-year-old, want to compare with the patient who's a healthy 35-year-old. Now, this is the recent paper which we published, and this is the last demographic data we have from Saudi Arabia. This is a hospital-based study. We find that osteoporosis in men is much more than in women. Here, the osteoporosis, if you see, is 63% in men. This is the hospital-based population. If you compare them to the women, it's about 52%. So unfortunately, this discrepancy is lying between our own diagnosis of osteoporosis in men and women. Now, the incidence of osteoporosis has been realized in children, particularly when I used to do scoliosis in young girls. We realized that osteopenia and osteoporosis was much common in children who are coming for scoliosis. This was one study which we published in 2008. We compared the DEXA scan in scoliosis patient and then their unaffected siblings. And we found that the osteoporosis and osteopenia was quite common. Now, the last study which came in 2023, published in European Journal of Spine, supports that our old view of 2008 that osteoporosis is common. Another one which came in neurosurgery, published reviews in 2019, suggested that pediatric patients who are going for surgery, for scoliosis particularly, are risk for pseudoarthrosis if they are having osteoporosis, nutrition deficiency, or metabolic bone diseases. Now, this could be a perfect fixation, but if a patient is having osteoporosis or osteopenia or vitamin D deficiency, then this could fail very easily. So how do we investigate children who are coming for scoliosis surgery? Calcium and phosphorus is the standard one, 25 OHD or vitamin D, and PTH hormone has to be done, because PTH is a right index to give vitamin D deficiency. 25 OHD may not, because the different methodology is used, have got different levels of false positive and false negative. Now, if vitamin D is low, we have to maintain up to 30 nanograms per ml, and if the Z-score is -2. If the Z-score falls below -2.5, then this requires anti-resorptive treatment. Now, anti-resorptive treatment we give by means of bisphosphonate, and then they should continue to have this treatment till the surgery is completed, and then at least for a year post-surgery. Now, in the adult's spine, usually the waiting period of surgery is between 6 months to 1 year. I don't know what is the situation in Riyadh, but in Sharjah at least 12 months is the usual. So if we investigate them particularly early, then it is much better for the sake of the patient that they will not fail the implant. Now, in the next 2 lectures, we will see about the methodology of different type of screws which will not cut out, will be presented. Now, this will be a perfect case of very horrible kyphosis, but at the same time you see the patient has got a artificial hip. This means that patient had a fractured neck of femur, which indicates that she must have severe osteoporosis. If she is not treated properly for that, the failure of this implant will be 100%. Now, this is another one patient where patient was treated early without any proper investigation and treatment for osteoporosis. The screws cut out in about 6 weeks' time. Now, because of the lack of time, I'll go a little bit faster. This is the FDA-approved medication. The first 4 of them are anti-resorptive. The last 2 are anti-resorptive and anabolic. Why we need anabolic? Anabolic we need to build the bone back. Anti-resorptive will only stop the further loss of the bone. Now, this is a head-to-head trial which was done between a teriparatide, which is a anabolic, compared to anti-resorptive. We see in the green color bar, which shows that even with the anti-resorptive, the fracture incidence was higher compared to the anabolic agent, which is in blue color, it's 0.4%. Now, this was the result of that study, saying that in cases of with the osteoporosis, it's much better to use anabolic. Now, there was one large study which was randomized and controlled in the university hospital. We did in about 415 patients where we used the anabolics, and we found that the gain of the BMD was much higher at the lumbar spine compared to the hip. And this indicates that if you are using anabolic, the bone will be much more stronger to take the screws. Now, pre-treatment for anabolic is again assessment by vitamin D and calcium. PTH level has to be normal, and absolute contraindication is malignancy or post-malignancy and pregnancy. The duration for this treatment is definitely 24 months. The reason being, if you see the 4 biopsies which were done on patients who had teriparatide, the anabolic does not work at least for the first 6 months. If you see the patient on the baseline, there's a lot of gaps in between the bone, whereas when it reaches 6 months, little bit, and by the reach of 12 months, the complete bone is reformed. Now, a new medication has come recently, about a year ago, which is much more stronger, and it has a dual action of anti-resorptive and anabolic. This is an anti-sclerostin antibody. It's a monoclonal antibody, which is there. But this, I just show you the differences between the placebo and the romosumab. The gain of the bone is about reaching 18% compared to placebo. Here, I'll go for the comparison between the teriparatide and romosumab. The gain is much more like 100% between 10 for romosozumab and 6% in teriparatide. So it shows that the anti-sclerostin antibody is a dual action, which is anti-resorptive and anabolic. The only issue with this is it has got a large dose of 210 milligrams, where 2 injections has to be given at the same time. The only issue with romosozumab is a high risk of MI during the treatment. So you have to be sure that this patient does not have a risk of cardiac disease. To sum up, osteoporosis is very common among patients who are going for spine surgery. Pre-op investigations can be done easily, and treatment of osteoporosis is not a rocket science. It is simple 4 to 5 drugs which can be followed up. And then follow-up with anti-resorptive should be continued at least for a 2-year period. Now, osteoporosis is a disease like diabetes or hypertension. If you stop the treatment, the disease will grow up. The only thing is that the treatment is long, but at the same time, we can always have a drug holiday after 5 years of treatment for about 6 months to 1 year, and then the treatment has to be restarted. I once again thanks the organizers for inviting, and I hope we'll have a good meeting today. Thank you very much.